Hello, everybody. I have a really interesting guest today, and we're going to be talking about a super fascinating topic. And what that is depression. A lot of people say they're depressed. Are they depressed? Well, I have a doctor who's going to help us decide what clinical depression actually is, but more so, what it might be rooted in. What are the causes of depression? Could it be rooted in nutrition or lack thereof? Maybe we're not getting what we need. Well, my guest today is Dr. James Greenblatt. He's a medical professional, a psychiatrist by training, and he is going to help us understand depression, the root causes of it, and how it maybe could be treated better with new advances that are coming onto the market and into awareness of the medical community and the community at large. So thank you very much, Dr. Greenblatt.
Thank you, Dan, for having me. Looking forward to our conversation.
Now, you look at depression based on your website in a very different way, but could we first start off with, from a clinical perspective, what is depression? It's a name that gets thrown around a lot, but let's get it clinically defined first.
Sure. I mean, I think the easiest path of thinking about depression is starting with sadness, which is an emotion that we all experience and normal. And when I use the term depression, it's a medical illness. It's kind of beyond sadness. It's a list of symptoms based on feeling sad and hopeless and helpless. It affects sleep and appetite, motivation. It's a long list of physiological changes that take place in your body.
Now, that's interesting because when I meet people and they say I'm depressed, my first question is usually, well, before I recommend a doctor to you, that you should probably talk to if you actually think you're depressed, is there something you're depressing? Because I often think of depression as a verb, not this noun kind of thing, something that something's pushing down and maybe they need to get out. What do you think of that? And how would you separate that from a clinical diagnosis?
Sure. Again, the terms that we use you can be confusing and they describe how you're feeling, but I think it's really important to kind of isolate the word sadness and the feeling and a sustained kind of inability to function in a capacity that you need to, be it with family, friends, or at work. So it's that sustained kind of progressive feeling that you understand there's something not right. And sometimes it's hard to communicate that. And people just use the word, I'm depressed. And other times it becomes incapacitating and people, tragically try to kill themselves and complete suicide. But I think the most important thing I can share is sadness is a feeling and depression is a medical illness that can be treated.
Mm-hmm. Now, another word you see online a lot is anxiety. Can you tell me where anxiety fits into depression, or is it totally separate from a medical perspective?
As a psychiatrist and as a physician, it's totally separate in the cause and the symptoms. But it's connected in that many people have anxiety and depression together.
Mm-hmm. Okay, so now someone presents themselves to you or their doctor and they say, I'm feeling overwhelmingly sad. What happens with that after that has been expressed?
A detailed history is the most important part of evaluation with a psychiatrist, to understand the history. And for me to separate, is it sadness? Was there a loss? Was there a stress? Was there a trauma? Versus the depression?
Mm.
Then is where I veer off from my colleagues pretty pretty dramatically, I guess, is that my colleagues in psychiatry would take that symptom and call it depression because they make that list of criteria and give an antidepressant. There's
Mm.
no concept in our traditional psychiatric model for looking at any underlying biological cause. It's just symptomatic relief. You're depressed, you meet criteria, I did my evaluation, and I'm going to give you a medicine to treat that depression. And where I veer off, I say, wait a minute, I know 30 biological causes that might be contributing to your sadness and depression. I'm going to look at those causes before I prescribe a medicine.
I just love that you said that. And that is why you went to the top of the pile of people I wanted to interview, because I've spent 30 years working in the pharmaceutical industry, but I've been 40 years in observing alternative medicine and ways that nutrition, primarily nutrition, and how people can look at things differently. And it's an overused analogy, but I always say, wait a second, a Ferrari is a really cool car, but it does not compare to the human body. And no one would put, crappy gas or motor oil in their Ferrari and expect it to run, as high performance. And that Ferrari can be replaced. But when people don't look at their bodies, enough people don't look at their bodies the same way, that this is one super fine vehicle and we need it to last and we want it to optimally function. So I love that you zoom in on this. I need to know more.
Absolutely. I mean, I think, Ferrari, brain, the brain is, 2% of our body weight, but the most metabolically active organ, right? 25% of our energy, our calories, our vitamins, our minerals, is utilized by this brain. And if we don't absolutely provide the correct nutrients, then it's not going to work appropriately. And I think one of the more important parts of the work that has evolved in my career is sometimes it's not dietary related, it's genetic vulnerability. And that genetics has really exploded in terms of understanding that one person might need higher amounts of a certain micronutrient. The next person might have the genetic predisposition where they can eat all the junk food and never exercise, and everything is just fine. We all know those individuals. But as we kind of understand genetic vulnerability with the environment, we can paint a more what we call precision, personalized psychiatric treatment model.
How did you start to, they don't teach much nutrition. They don't teach this kind of stuff in medical school. And I can imagine wasn't taught when you were going to psychiatric, to get your psychiatric degree. How'd you start to go in this direction? What made you swerve from the path?
Well, I was fortunate that I didn't have to go into the direction. I started there. So I went to medical school thinking I was going to cure the world with brown rice and kale, 40 years ago. And, I came out a psychopharmacologist, 9-10 years later as a child psychiatrist learning medications. And so it was just a couple of years into practice where I said, wait a minute. And so very early on, so I've been looking at nutritional and metabolic psych for about 30 years now. And helping doctors understand the role of nutrition and metabolic psychiatry and trying to reach the patients as best we can.
Now, you mentioned rice and kale, so that reminded me of Adele Davis. And then we could go through other people nutritionally throughout the years. And diet advice is swings like a pendulum. And, we're seeing it even more now, one day butter's in, next thing it's out, then it's back, and red meat's in. No, don't touch that red meat. No, now it's back. What are some overall trends that you think could help everyone emotionally be a
Sure.
little more balanced, or help their bodies be a little more regulated?
Well, I remember reading Adele Davis when I was in high school. My mother had the book. So, and she probably was, 99% correct in what she wrote, 50 years ago. But I think the field now is ready to kind of embrace nutritional medicine for mental health. But
Mhm.
I just think the most important part of my work in what we call functional psychiatry is this concept of biochemical individuality.
Mhm.
Everybody's different. And I don't know where this got stuck in my head, but every time someone asks about diet, I just think of the Eskimos living on fat and blubber and the vegan societies living in, certain parts of India or in Africa. And I mean, all over the world, humans have adapted to very different diets.
Mhm.
And we can talk about the blue zones and we can talk about, different areas, but I think, particularly the past 5 or 10 years with genetics, everyone is unique. And I think we all know there are those that can do very well on a carnivore ketogenic diet, and others, I'm quite convinced now, there's genetic, differences where they're not going to do well. So
Mhm.
I think, the closest thing to health would be, in terms of dietary intake, is eliminating the ultra processed foods and refined sugars. So
Mhm.
my example is not in psychiatry, but we have research like on cardiovascular disease. So there was improvement on people eating, the low carb diet. There was improvement in people eating the high carb diet, and everything in between. And the only variable in all these studies was what they eliminated. These
Yes.
research studies, they eliminated the ultra processed foods and refined sugar. So to me, that really is the goal. And then kind of know your body in terms of what is most comfortable.
It's so funny you say that, because my first health book I wrote, oh God, you have to just eat vegetables, only vegetables and nuts. And my blood work was phenomenal. My next diet book, I wrote, well, you should eat vegetables and meat. That diet book was well received, and my blood work was perfect. My third one, I said, I kind of miss bread. So I added some whole grain breads back in, and I'm still just fine. And so, but what don't I eat? Processed foods. It's very rare. And so,
Absolutely.
it's interesting what you just pointed out, because I never thought of it from that perspective, that it's what's been eliminated more than the core ingredients to some degree.
Right. I mean, we're always looking for nutrient dense foods. We're always looking for the rainbow of, fruits and vegetables. But and then I'm just going to keep coming back that, everyone's different. So, celiac disease and gluten sensitivity is a significant problem for many people. It is actually related to depression and anxiety for many people, but not everyone. So there are some people that can eat gluten and do fine. Others, we've had patients from having psychotic illness to depression and anxiety that completely resolved by eliminating gluten.
You know, you mentioned, um, how did you put it? Functional medicine. And a lot of what is people talk about with functional medicine is they just want to feel good. They're more focused on the physical side of that feeling good instead of the mental side. Now, you've mentioned gluten, which a lot of people talk about, and people will say, oh, I just feel bloated. But you don't necessarily hear people say, well, I notice my moods go off from it too. So that's an interesting observation you've made, which I'm sure is clinically based on your background and research.
Absolutely. I mean, the research is clear that almost 50% of people with celiac and gluten sensitivity do not have GI symptoms. So they present to their doctor a fatigue, sometimes depressed, sometimes anxious. We've seen it with uh, patients with anorexia nervosa. So they present with these physical, emotional symptoms, But our mental health professions don't look, well, maybe there's a dietary factor. Maybe they're depressed and anxious because they're not absorbing the nutrients in their food, because celiac disease destroys the entire intestinal villi to absorb these micronutrients.
So what does the medical community at large think when they hear, oh, there's James Greenblatt, coming in with his perspective on nutrition instead of sticking with the rule book?
Well, great question. I think
prescribe.
25 years ago, I slipped into the field of eating disorders. So working in hospital settings, in residential with men and women with eating disorders. So there, I got to talk about malnutrition. And so for 25 years, I was rooted in traditional medicine, and I could give lectures on, vitamin deficiencies and mineral deficiencies because we were discussing malnourished patients.
Right.
So, I think I was respected in the eating disorder field, although the community still doesn't routinely give micronutrients, which is life-saving for this population. But the last 5 years, things have changed pretty dramatically because the research community around the globe has published papers on nutritional deficiencies and depression, anxiety, suicide. And recent studies have supported many of the supplements and micronutrients we've recommended for 25 years. So I think I've gotten a few emails and texts recently about people saying, you said this 20 years ago, and the research is now supporting it. So it's a very, very good time.
It usually takes about 20 years to become an overnight rock star.
Correct.
But SSRIs are in the media a lot right now, as are GLP-1s, people saying, oh, they're going to, the SSRIs are, coming under new exposure again about suicidal tendencies, depression, and other problems that they have, shown in clinical trials, not necessarily elevated in subsequent media. And on the GLP-1s, all these people doing these for diets, and having looked at clinical trials for many years, I'm really starting to wonder what the pluses and the minuses are there. And yeah, you might lose some weight, but what else is going off balance? Can you give me your perception on that and your thoughts?
Sure. I mean, I think
topics. I realized there were two different.
Yeah. Those we could take an hour for each, but the SSRIs are, I was there in the 80s when they came out, and miracle cure, no side effects. And for years, we just prescribed them without thinking. And then all of a sudden, we started getting that, Prozac backlash in the books and the TV shows. People, survivors of Prozac was one of the, TV shows, or Phil Donahue shows. So I think, I haven't thrown away my prescription pad. There is a place for antidepressants, but they're clearly overused, and people are clearly, as you described, missing a black box warning that there's a subset of people that develop aggression and suicidal ideation from these medications. This is listed in the drug insert. And for years, I didn't see it at all when it first came out, and it didn't make sense. But when I started working with malnourished patients in the eating disorder unit, I saw it all the time. So I've seen acute suicidal ideation on these antidepressants. And it's usually in the first 2 weeks.
Side with malnutrition.
That has been my correlation. Nobody else has written about it, but I didn't see it before I started working with malnourished individuals. Then they were put on these medicines. They described intense suicidal ideation that they didn't have before. We stopped the medicine and it disappeared.
Well, you know what doesn't surprise me about that? My first exposure to working with the pharmaceutical industry was the drug Redux, which was introduced 20, 30 years ago as the first diet drug in 20 years, and then was pulled off the market. And that was the fen-phen controversy. There was Redux, and then there was fenfluramine and dexfenfluramine. And Prozac, I remember Eli Lilly wanting to go to the FDA and say, well, we've noticed people on Prozac don't want to eat and they're losing weight. And the FDA came back to them and said, well, that could be true, but no, you can't just claim it as a weight loss drug. You've got to go back and do clinical trials. So it's so interesting to me that you observe this, the people on, let's say, a Prozac, because they were feeling less hungry. So maybe they were hurting what they were eating, absorbing nutrient-wise, which I never thought of until talking to you. Or maybe they just weren't hungry enough to eat the things they needed to eat and went for a well, no offense to chocolate. I like chocolate. They went for, chips instead of a meal.
Yeah, absolutely. When we think about the life-threatening illness of anorexia nervosa, there's no FDA-approved medications. And even though patients are put on medications, and these medications are supposed to keep this neurotransmitter serotonin around longer. But as you described, they're malnourished. They don't have the precursors or cofactors to make serotonin. So the medicines don't work at all. But we have seen this subset with increased suicidal ideation. And we've seen it with other patients that aren't eating disorder patients, but what we discover is they are malnourished and have significant nutritional deficiencies.
Now, what are you observing? We won't name them, but we could. All the GLP-1s that are on the market, and that new category that's burgeoning, and I think it's 1 out of 8 Americans are on them right now. How do you relate to that nutritionally, and then therefore mentally, and what you think could end up being?
It's very, it's like everything now that touches mental health. We have so few tools to help our patients that when we find something that works, we get carried away, whether it's ketamine injections or GLP-1. So in the mental health world, there's research looking at alcohol and many other problems looking at the GLP-1s. I think they can be incredibly helpful as a short-term intervention for things like binge eating disorder, and certainly medically is not my specialty, but diabetes is how they were developed, and weight loss can be helpful. But they do, as people kind of limit their food intake, they also limit their micronutrient intake. And so we see those complications. There are supplement companies now that are just developing supplements saying, take your GLP-1, but take this particular special vitamin. So people are trying to market around, these dietary restrictions on these medicines. So I think, like so much else, there is a benefit. I mean, I think they're an incredible opportunity, but it's just overused, and the consumer now is kind of in control, helping to kind of drive this mania around the weight loss.
Well, I was pretty fascinated. I was at a Thanksgiving dinner, and there was never more food left over. I had never seen the amount of food left over in my life. And as I'm talking with people, I'm finding out, oh, well, I'm taking this, I've been doing this, I've been doing that. But when dessert came, it got devoured. And then I'm saying to people, wait a second, so you didn't eat the main meal? Oh, I'm not that hungry, but I love dessert. Like, whoa, where is this all going to go? By the way, everybody, I am in New York. I'm not, and if you notice that ambulance, no one's coming for us. It's just ambulances on the street because I'm not in a soundproof room. Welcome to New York City.
You mentioned the GLP-1s. I read someone came up with a term that gets called agnos, some new term based on an eating disorder based on GLP-1s. So it's so agonosorexia, something like that. But it was just because it is creating a whole new class of disordered eating.
Mm-hmm.
That is a problem. But there's some incredible benefits, and I've particularly in my field of eating disorders, people with binge eating disorder, inability to control their food intake, can, over a period of time, while they're working in a therapy session, while they're helping their nutrition, the GLP-1s can really be dramatically helpful.
What are things you recommend these days? Like after you've determined someone is clinically depressed, how would you proceed with that in your practice, or what are you guiding other practitioners to do?
Well, the whole model is testing, is,
Mhm.
don't guess, don't just provide some symptomatic based treatment. I mean, St. John's wort without testing is the same to me as Prozac without testing.
Mhm.
So we look at what might be contributing. And some of it is really simple. Iron deficiency. How many psychiatrists are seeing if you're deficient in iron? Thyroid, low testosterone, B12, vitamin D. I mean, they've all been clearly associated, some for 30 years, with depressed mood and lack of motivation. And so we have to do the testing first. So that's kind of the overarching theme of what we call functional psychiatry. Doesn't
Do
mean we're
you
not going to use medicines.
do you have customized panels that you've established where you say, listen, these are the things we're going to test? I mean, you just listed a bunch, but do you like say when we do blood tests, we're going to focus on this, this, and this and narrow
Yeah,
down? Or-
absolutely. And the new book, Finally Hopeful, kind of outlines that and try to help patients, be a little more strong advocates for their health with their doctors, and for doctors to understand these are contributing factors and look for them. And everyone's different.
Let's talk about that new book you have coming out. And everyone, there will be all kinds of links to it below. But let's hear about it. What made you write it, and what might someone find in it?
Well, it's based on 30 years of clinical practice treating depression. But what kind of stimulated the reason to get the book out there was it wasn't my opinion anymore. There was research from every academic medical school to say, this is what happens when your vitamin D level is 15. This is what happens when you're not digesting your food. This is what happens when you have celiac disease. So I just felt I had the research to support a program that is just desperately needed, because our current model of mental health treatment and outcomes is pretty bad. And that was the motivation to get this book out there.
Now, in the book, is it peer-to-peer, or is it something that consumers would want to pick up?
So it's written for consumers. It's kind of the style of my first book, Finally Focused, for ADHD. And what I found over the years is that at least 50% of the readers were professionals who didn't know this work. So I think it's a great tool for professionals to learn about integrative and functional psychiatry, but the audience was for patients and consumers who want to improve the treatment that they've been under that has been kind of stagnant.
And can you tell the audience the title of your book?
Well, I think that's the best part of the book. Finally Hopeful. So it's finally hopeful because too many patients struggling with depression have just lost hope. I mean, they feel like a guinea pig with their psychiatrist who just prescribed the next medicine. Then they go to an integrative doc who just prescribes the next supplement.
Mhm.
And so I just wanted to get the word hope, in the title and to be the theme throughout the book. Because if you do this deeper dive, you will get relief. And you might need to continue medicine or use medicine. It's not an either or. But without looking at nutrition, without looking at metabolism, without looking at hormones, you unlikely will optimize your moods.
Something I had read on your website, you mentioned lithium. And it's interesting because when I think of lithium, I think of like the 1950s and mega sedation. And now I've seen increasingly articles talking about micro doses of, I guess, a form of lithium. But can you elaborate on this?
Sure. Those are one of those things I started talking about 30 years ago, and I guess I could say I told you so. So lithium orotate, it's been a major part of my practice for 30 years, helping individuals with depression, irritability, impulse control, and addiction. And it's not lithium carbonate, the medication we use for bipolar. It's lithium orotate. And lithium is a natural mineral in our food supply and our water. It's essential for brain function. And one of the major research studies that came out last year was on lithium orotate, a Harvard study published in a prestigious journal, preventing and reversing Alzheimer's. It was just an incredible research article. They also did brain dissections to find low levels of lithium in the Alzheimer's brain. And they demonstrated that lithium orotate was the only micronutrient to reverse the plaques and tangles we think about when we think about Alzheimer's.
That's fascinating. And that's going to be a big soundbite, because let me tell you, a few years ago, a company commissioned me to do a survey study and some polling. And it was about, what were people most concerned about? Cancer, heart attacks, blah, blah, blah. No. Everybody viewed those as treatable. Nobody wanted to lose their memory. Nobody wanted Alzheimer's. That was so far ahead of cancer or a heart attack. It was mind-boggling. Like, I'm talking about a huge gap, like a 25% point gap out of over 1,200 people.
No, it's pretty frightening. And what's happened since this article, I get emails now with all these new lithium orotate supplements. Everyone, and they're adding, I saw one with ashwagandha and theanine. People are just adding to make their supplement better, but they all now have lithium. And I urge people not to take these supplements with lots of different ingredients.
This is what I want to get to. And you're the guy to talk to people about this, because I think it's incredibly important. Everybody's a Google doctor now. They're deciding what's wrong with them. They're walking into their doctor telling them. I think there's a lot of good in that. But where I think things go awry is a lot of, drugs go through clinical trials with the FDA. Nutraceuticals can kind of make any claims depending on how they market them in different ways. And people, I talk to people and they're like, well, I take these 20 different things. I'm like, whoa, where'd you come up with that? And do you have any idea how they might interact? And where'd you come up with the dosage? Like, why are you taking 10,000 milligrams of this and, 5,000 of this when, a little of multivitamin has minor amounts of that? Like, where did you decide all this? They'll say, well, my favorite influencer. I'm like, oh my God.
Yeah, I used to call it label therapy. So there's a research article that says vitamin Q, helped the rats, and so so then they just make a product and has the vitamin Q in it, and the doses doesn't matter. It doesn't matter if it was rats and humans. And now, as the supplement industry needs to keep selling different supplements, they're just adding ingredients because, you heard ashwagandha is calming, but the dose has nothing to do with it. And exactly what you said, the combinations that people are putting into these supplements, they're just made up in their head and they have no understanding of the interaction. And I just urge people to caution with these kind of multi-ingredient supplements. Focus on what you're deficient on, take it, and understand how it interacts. Don't get taken by these labels. It's really frightening and potentially dangerous.
Yeah. Are you the only person with this perspective? Are you teaching people, or can other doctors find out about what your philosophy is here in your practice?
No, absolutely. There's a community around the globe that have been doing this work for many years. We have a conference that is called Integrative Medicine for Mental Health that has been, I think, 15 years now. And we have an education platform called Psychiatry Redefined. And that Psychiatry Redefined, we've probably trained thousands of clinicians. We have people from 16 different countries who learn functional psychiatry. And the last couple of years, we have it's just growing because people want the information, which is making me hopeful that we can really shift this model of mental health care.
If someone recognized they were depressed, thought they might need medical help, what would be the route you would tell them to, or the questions they should ask to try to find someone who would look at psychiatry and depression more like you are than maybe just plain, well, here's a pill, let me know how you're feeling in a couple of weeks?
Yeah, no, it's challenging for patients and consumers because they go to a functional or integrative doctor, but they're not trained in mental health.
Mm-hmm.
Then they go to the psychiatrist who's not trained in, the functional or nutritional side. So hence the reason for the book. And it's challenging, but I think the most important thing would be advocate with your primary care doctor about testing. I mean, we could change the face of depression by optimizing vitamin D levels across the planet. I mean, there are a billion people deficient in vitamin D. So, using something like the book or just advocating with your primary care doctor to get these tests done. Am I deficient in iron, thyroid, or B12, or vitamin D? And there's a group of us now forming a kind of virtual clinic to provide consultations to help patients. And that should be open, by the end of February.
And would people be able to order a panel through that?
Absolutely.
A lot of it is you go to a doctor and it's like, well, what do you want to get tested for? Well, I want to know X, Y, or Z. They're like, well, that's kind of over here and that's over here. And then you have a deductible, blah, 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 blah. Like, I think people need direction as to what to ask for.
Absolutely. Yeah. Hence, that's what we outlined in the book. And that's what the clinic would be. The testing would be done all before they see the psychiatrist.
Mm-hmm.
So then the psychiatrist sorts through the clinical history and tries to understand what's going on. And is it a thyroid problem? Is it a gluten sensitivity? Is it a genetic vulnerability? And that's the information that gets kind of personalized to the individual.
Medicine has become so fractionalized in so many ways. What's your hope for the future on that, of where a patient can really be viewed more holistically instead of as a series of parts? That they go to one place for this and another place for this, and there's little conversation between this guy and that woman and this doctor over here.
Well, I think I've spoken to some very brilliant people that are putting, good use of AI. And I think that there's be some AI tools in the next few years that can really integrate someone's medical record and their laboratory tests and their clinical symptoms. So I think it's a pretty exciting time as nutritional medicine is getting, some well-respected press. And as you said, the ability to integrate tools with AI can be, I think, very exciting.
It's a very interesting development where AI can be used. When I lost my hearing, I went to a bunch of different audiologists and I took the test. I couldn't believe it because Elon Musk kept saying, put it in Grok, remove your name. I took my audiology test and took pictures and put it into Grok with no name or anything, no identifiers. What came back, I then went to a next audiologist who said, where'd you get this? This is the most unbelievable. Who did this? I want to know who they are. Grok. It's mind-boggling.
Well, think of tools that would be able to integrate your medical record, can read your entire history of what happened when you were born, to your labs, to your genes. So they'll have access, the AI tools will have access to all your genes, which is truly amazing. And over time, just kind of work with you and work with your doctor primarily to better understand your health risks and your health treatment.
You mentioned genes earlier and genetic testing, and I'm just curious, what do you think about genetic testing and the idea of, well, you could have something show in your genes, but then there's the idea of triggering it?
I at this point in my career, I think it's, not quite malpractice, but it's poor care to not look at certain genes when you're treating a depressed patient, particularly what we call treatment refractory, someone that didn't get better with therapy and meds. So, there are a number of genetic tools that we look at, some, called nutrigenomics, looking at like vitamin D, I've mentioned a few times. There are people that have very significant genetic vulnerability to needing high doses of vitamin D because they don't utilize it well, their receptors aren't active, and so we can test for that. And then there are also genes that tell us about how you metabolize essential vitamins for brain function, like B12 and folate. And these simple tests can guide my treatment, and for many have been the answer to the reason why they haven't gotten better on current treatment models.
That's very informative. Good to know, and a good thing to request. As
Absolutely.
Yeah. Well, oh my gosh, this has been a thoroughly delightful, highly informative conversation, and I really appreciate you spending time with me, Dr. Greenblatt. Thank you.
No, my pleasure. Appreciate the time and your very astute questions. So,
thank you. Well, don't hang up yet. We're going to move over to the green room. I'm Dian Griesel, and this has been the Silver Disobedience Perception Dynamics podcast, where I interview the most interesting experts in their fields. And the fields are varied. They're all over the place, but they are highly knowledgeable, enthusiastic about their work, and willing to share it for us so we can all live better, longer, more happy, loving lives. So thank you for tuning in, and thank you, Dr. Greenblatt. Oh, and all links to Dr. Greenblatt are going to be below, as well as links to his book. He's got at least a couple out there that he mentioned during this show, and there will be links to both because they both sound fascinating to me, one on depression and one on ADHD. So I highly recommend you check them out. Thank you. We're moving over to the green room. Hit subscribe, everybody.